Good morning, everyone. Thank you, Jan. So I'm going to start my talk today leading into what Bala's going to speak about, which is really responding to the pandemic and how to unlock data in a time of crisis. But I'm going to introduce actually the concept of how to unlock data, period. So McKinsey says that health data is the new oil. And I kind of challenge that because oil is static or finite. It's unavailable unless you tap it or pipe it. And that's probably the only area where oil and health data correlate, is our health data is unavailable to us if we don't find ways of tapping it and analyzing it. So I'm going to do some introduction today of what that data is and ways that we can start piping into the data and unlocking it. So we will go over the use case of how Rush Medical Center used one of AWS's services at the very beginning of COVID-19, which was rising and it was peaking in Chicago, and they needed to respond to a health crisis there. And Bala's going to go into full detail of that use case. But I'm going to talk a little bit about one of the new services that we launched in GA a couple of months ago, but actually Rush Medical Center was given access to it early on, called HealthLake. And I'll describe a little bit of what HealthLake is and how it is useful for unlocking health data for people even that are not involved with machine learning themselves and maybe not a biomedical informaticist. So I want to do a little bit of history of where data has come from in healthcare. So I'm going to walk all the way back to the first data set that was actually started to be recorded by individuals who we would call maybe a clinician. Was back in 400 BC when the Egyptians started to analyze urine of sick people and look at things like, smell, taste, color, etc., and record that. So that was really the first health data set that was recorded. Start to fast forward, not a whole lot happened for a very long time in recording health data. But then, very interesting, in 1869, most of you probably, who thinks Watson and Crick discovered DNA? Well, they didn't. DNA was actually discovered by a Swiss person and in white blood cells, and he described it in totality. Watson and Crick actually modeled it and discovered that it was a double helix. So if you look at those two things, you could say that really unlocked biomedicine, both of those initiatives. But there were other things that started to unlock on the computational side. So we have the biology side of it, but also unlocking data was really this deep learning model, which was published quite a few years ago, and you might call this old school. I don't think it's old school because we use deep learning every day now. But it was really starting to apply computation to the theory of big data sets. Now let's kind of fast forward. Not a whole lot happened in the healthcare space with data until the United States actually created the Medicare and Medicaid government agency. And they started harvesting all of this large data in paper form from those individuals that qualified for those government programs. This was the first really, really large data set. Move a little bit forward and start to think about other things that started to develop, the development of the MRI. The first X-ray machine actually was with the first hospital in the United States, which was Penn Hospital, and was started by Benjamin Franklin. Penn Hospital had the first X-ray machine. So that was probably our first non-urine smell and taste set of data that started to be collected. But when the MRI machine came along, it really changed the size of the data sets. These are huge data files with a lot of intensive information. And just as you start to accelerate now, things are starting to build, they're being warehoused, they're films, we now digitize them. So all this information is needing to be tapped. Back to the oil example, it's not static. We're pumping more and more oil into the ground, but now we have to do something with it. And finally, another paradigm shift happened in the area of medicine, and this is starting to be the social determinants of health that we could tap into, which is the launch of Facebook. And Facebook starts to give us access into social media, and it's said that Facebook can actually predict when influenza is in an outbreak across the region. And I think that's probably true. But data in and of itself is extremely complex. Some of it is actually structured, and a lot of it is unstructured. This is an example from a paper by Zach Kohani at Harvard Department of Biomedical Informatics, where he starts to describe in 2014 all of these siloed data sets in healthcare, and the fact that we are going to need to discover ways to tap into it one way or another. And he's just proposing, we need to understand that if you're going to have a look at a patient like mine, for example, if you're a clinician and want to see what a patient like yours looks like, or you're a research scientist and you want to understand larger population health questions, you've got to tap into really large data sets. So AWS is addressing this with our AI ML technology, and we have a stack of technology that really starts at the high level, up on what's called the AI services level. And AI services are services available where you can spin them up in the AWS cloud without having a lot of AI ML capabilities. They're sort of intrinsic to the user. And I'll call your attention to the upper right-hand corner. There are 3 specific services for healthcare. The first one, which I am going to talk about briefly, is Amazon HealthLake, again, which was launched in July. And the Rush team used this, and it was in an early look for the COVID use case. And then Comprehend Medical. Comprehend Medical is actually AI that extracts from text, and it extracts ontology of medical words. And Comprehend Medical is also embedded within HealthLake itself. So in HealthLake, you get both of those capabilities. And then finally, Amazon Transcribe, which takes verbal information, conversation, and transcribes it into a flat written document, which then you could apply, for example, Comprehend Medical to. So if we look at the current state in this digital transformation and how we have to tap the oil, right now, if you're looking at, for example, if you're a clinician and you're looking at your patient and the data sets and you're in the EMR, you're probably looking at less than 30 data points. And that's not extremely helpful overall to start to get a picture of what's going on with that individual today and longitudinally. But if you could tap into all of these data sets that do exist on that particular patient in various silos, and I show all of the examples of the silos in the middle of the screen, you could start to get to the level where you would have 200 to 300,000 data points on that individual instead of approximately 30. And that can be done with the new HealthLake platform. And what HealthLake allows you to do, and what HealthLake is not, it is not a data lake. So you're not going to pull in all of your data on every patient or your population as a whole and keep it there and store it there. You're going to import your data based on a particular question that you have that you want to answer. You're going to run AI ML that's native inside HealthLake, get your answer, and then export the analytics of that back out to another platform. What HealthLake does, though, is when you ingest the data, so I have a question, one, I can very practically import lab reports, x-ray reports, EMR reports, and let's say I want to ask questions about type 2 diabetes. I can pull that data in its raw form. HealthLake will actually transform the data into a FHIR format, or it ingests FHIR format, and it will then tag all the data and structure it for you. So you don't need to start with structured data. You can start with all of those, stovepipes all over the place. HealthLake will structure it for you. And then it makes available to the end user very simple natural language processing capability. So once your data set is ingested, you can start to ask it very simple questions by typing it in text format onto the screen, and it will pull the data and start to give you information. And here's an example. So I want to know about type 2 diabetes. So I go into my database, I look for all type 2 diabetics in the EMR system, I import them into HealthLake, and then I want to ask a very basic question, is who has type 2 diabetes as a diagnosis? Who has other comorbidities within their medical records? And longitudinally, it starts to grab all of this information from this now structured data, and it runs along the right-hand side of the screen an ML code. And then it comes back and it gives a prediction, probably hard to see in the back, but at the lower right-hand side, it tells me that there is a 97% correlation that the data that I've just pulled in actually is type 2 diabetes data. And then it does something else very interesting, is it gives you visualization and an analytics platform that you can start to look at that data laid out in a clean way that tells you what the data set looks like. In this case, it's one particular patient, and it lays out their timelines of their engagement with the medical system. It shows that this patient has arrived into the ER with hypertension, even though they're diabetic. It also does something very interesting. It picks up negated terms. So one thing about this patient is that they had never been diagnosed with hypertension before. So it picks up the fact that there's no hypertension in the record up until a certain date, and it notes that. So I quickly look at this and I'm like, okay, this is interesting. I see medication changes, I see the encounters, I see the procedures that were done, and now I want to ask additional questions. I can then go on to a more sophisticated, on the right-hand side of the screen, use of AI ML for tools like Amazon SageMaker, et cetera, and then build those into other platforms for visualization like Amazon QuickSight. So once you have it in the silo of a fully structured data set, you can look for your trends, you can look for predictions, and then you probably want to export it out because you're paying a bill for its storing. Every hour it's in Amazon, you're paying for it. So you want to complete that with using APIs to extract it back out into another less expensive platform to prepare it for further analysis or to send it to someone or share it for more data. And this is exactly what Rush Medical Center did in their process in the middle of COVID. And so as a brief overview, that'll give you an idea of one of the services that Bala's team used. And with that, I do want to introduce Bala to now give you a deep dive into the utility in the pandemic.
Thanks, Ken. Great to be here. I'm going to be speaking a little bit about the experience we had using, well, first of all, trying to bring together various data sources for public health in the setting of COVID, and just how that drove a lot of change from a regional perspective, but then also Ken very nicely highlighted this issue of data fragmentation and how we sort of sought to solve that. And then, underlying all of this is, of course, HealthLake and the Amazon AWS infrastructure to be an enabler for us to get this done. So, much like other sites in the country, we really got to live the experience of having a gap in our real-world evidence generation. Pretty quickly when COVID happened, the single thing that we really wanted to know is what's going on, who are the patients that are getting sick, who aren't. I'm an infectious disease physician by training, and so getting to the underlying epidemiology and what are the risk factors for COVID was a key issue. And as an academic medical center, we had experience trying to get real-world evidence together, and we used something called an OMOP Common Data Model, which you may be familiar with. It's a pretty standard data model for how you structure data. You have an ETL layer or transformation layer between your data warehouse or your EMR to this representation of the data, which is understood between sites, and the theory is then you can have common queries. You can have a standard set of queries to kind of phenotype or look at your data. And so we have Epic as our electronic record, and we have both Clarity and Caboodle. And so we had existing processes to pull data from those environments into OMOP. We immediately had a gap that we identified because our OMOP representation was updated quarterly. And we're also a participant in something called PCORI, which is the Patient-Centered Outcomes Research Institute. That was updated quarterly. Suddenly in March of 2020, this pandemic drops like a nuclear bomb into our city, and we immediately need to have questions answered. We can't use this wonderful research data model that we have built because it's not up to date. And now that's compounded by how do you then do multi-site data sharing? Just imagine you've got these individual federated representation of data all around the country, but academic medical centers, and the real gap that sites encountered was, okay, they cannot share these data. The data aren't updated. And when you most need the answers, you don't have it. It took like 6 months to 8 months to get data that was useful for multi-site collaborations. So sort of after the first wave of the pandemic. And we experienced this by just so many data requests from different places because of this just real hunger and shortage for data. And in addition to the data, there's problems around shared or common definitions. How do you define what constitutes a COVID-19 patient? What are the appropriate time points to share data? How do you count the number of hours on a ventilator? OMOP doesn't have out of the box a way to measure ventilator frequency. And how do you even standardize something as simple as definitions of race and ethnicity, which health equity and outcomes was a big deal in COVID. It is a big deal. So, and then there's data governance and legal, which is always the thing that slows you down at the individual site. So really what this got to is what clinicians wanted was a table 1 and a table 2. If you look at a New England Journal article or any article characterizing a new disease or some new study, there's a table 1, which is a patient characteristics. There's a table 2, which is outcomes. We wanted that, and we wanted it in real time across a network of hospitals. That was the ideal. And so we ended up, one experience of data sharing that we went through was to try to share our OMOP data model with multiple sites, and we were actually funded by the Robert Wood Johnson Foundation and Academy Health to do this in a project called Health Data for Action. And we went through some different experiences. We built kind of a standardized way to in real time update OMOP from Caboodle and to do it daily. We then wanted to open source that code, and we actually found to make it turnkey for any Epic site, and we found that Epic has a license agreement where you can't open source code that hits the Epic data model. So we ended up sharing it on Epic's user web, and that link is there. So even just that simple act of, okay, how do we standardize the sharing of data from Epic, from one EMR to standard data model, fraught with challenges and barriers, and we kind of went through that. So this is just one hospital and use of data for research, and the barriers we went through. But then from a public health regional perspective and national, we also went through some gaps and experienced some sort of challenges. And the biggest thing was there's enormous data fragmentation and challenges in the public health infrastructure to share data and collect data. There's something called a PUI, or person under investigation. Who here knows what that is? Okay, so person under investigation is somebody who meets the clinical criteria for COVID. So they're suspected of having the COVID-19 syndrome. And the traditional way that public health captures data is, and even to this day, but it's gotten a bit better, but it's pen and paper and fax. And there was actually a really nice series of articles in both the Washington Post and New York Times last year about this. When COVID first happened in March, the traditional way to do surveillance for this from a public health perspective is there's a form that has to get filled out that's a case report form. The infection control staff at a hospital or clinicians, but they never do this, if they see a suspected case, they fill out this form, and it has something like 80 data elements in it, and then they fax it to their health department. At the health department, someone there receives the faxes and manually enters that data into a database. And that's how the health department keeps track of who is sick and what the clinical features are of someone with a disease, with COVID. And that same system is used for tuberculosis reporting, for salmonella reporting, for HIV reporting, any kind of public health reporting, pen, paper, and fax. So you can just imagine sort of the administrative burden of these sort of systems. So pretty quickly, it was realized that data was missing. People weren't submitting the forms that were submitted were incomplete. And so on the left side, these were the data limitations and the missing data that was found. So first of all, race, ethnicity, hospitalization data, underlying conditions, and length of hospital stay, all data elements on this form, data was missing on the paper forms. In addition, there was just a ton not reported. Only 22% of cases were actually reported via this form, this electronic form. Now, in addition, in meaningful use, so who here is familiar with meaningful use? Okay, great. Yeah, so meaningful use is this legislation that drove EMR adoption. Part of it, there's always been a public health carve-out in meaningful use. And these are mandates, which is nice. Electronic lab reporting is a piece of meaningful use. And so what that is for certain diseases that are legally required to be reported to your local health department, all EMRs must submit that data to the health department, EMRs and labs. So that, in a way, has been an enormous success because 78% of the data was through this ELR submission. It was automated. So it makes sense. Automated submission is more complete and more timely than manual submission. It's just that the rest of the public health infrastructure hasn't caught up. ELR is very limited. It's just a test, the patient name, demographics, whatever is on an ADT feed, and the test result. So you don't know anything about their hospitalization or clinical course or anything. And so this led to some real big gaps. And in the MMWR, they basically said no data on serious underlying health conditions were available. Data were preliminary and missing for some key characteristics. And so basically, you knew the prevalence rates and incidence rates of COVID and test results, but you didn't know how patients did. You didn't even know if they died in this framework. So the city of Chicago kind of recognized this, and it was a coordination between, the Rush CEO, who really wanted to know bed information, because there's a whole thing around bed transfers and serious illness. That's a health equity gap. You really need to know what's regional usage. And then severity of illness and demographics. We worked with the health department, the City of Chicago Health Department, as well as some national leaders, including Anish Chopra, the former CTO, and Farzad Mostashari kind of helped us a bit with this as an advisory role. And we basically, the City of Chicago put out a public health order. And the public health order mandated electronic submission of certain data to complete this record. And that included, of course, the ELR, but also CCDA records, which are continuity of care documents. They're this sort of comprehensive data around the entire encounter for patients that traditionally are shared hospital to hospital. In the city of Chicago, due to this order, it would be for COVID patients or people tested for SARS-CoV-2, that data went to the health department. And then bed information. What are your occupied beds? The type of data that normally goes to HHS Protect or EM Resource. That data now goes automated. And as a part of this legislation, Rush was contracted to become the sort of developer and maintainer of a data hub. So the data hub essentially pulled in data from different elements. And in the middle panel, you can see right there, this is the data hub. And so it's basically Care Everywhere type data. So Care Everywhere is Epic's CCDA data exchange framework. But it includes non-Epic sites like Cerner and eClinicalWorks, Athena, GE Centricity, et cetera. Secure FTP as one mechanism of transfer, but also direct messaging. And then the FHIR API is a mechanism to share the data. Plus ELR data from the state health department and bed capacity information as a flat file. That was sort of the set of requirements in the public health order. that gets aggregated. So it's a really simple set of requirements. It's legally mandated data that you already should be able to produce, so no extra burden, but let's just share it all for the relevant people to the health department, connect it, have an EMPI to match the patients, and then be able to run epidemiology off of it. And then this becomes kind of a foundational component to public health infrastructure, and basically it's a registry at the public health level. It's a COVID-19 clinical registry. That's what this develops. The CCDA gives you tons of information. It gives you encounter information, it gives you did they die or not, it gives you their medication, their problem list, and suddenly you can start looking at comorbidities, you can start looking, you get an additional source of race ethnicity data to validate, and it becomes super useful. So it's, as with these projects, it's not the technology, right? It's getting the buy-in. So the public health order, what that enabled and why that was an incredibly bold move by the health department, it gets rid of the need for business associates agreement, because BAAs between all these hospitals would have taken forever. Instead, because it's legally mandated, it's the same framework as communicable disease reporting, and so hospitals could just share the data, and it's for a public health emergency, so the PHI can be shared. So that got through that whole barrier. Then the institutional buy-in, because it was a COVID-19 emergency, tremendous amount of goodwill. The one thing we did was we coupled it with some data governance activities where every hospital got a seat at a data governance committee that this health department chaired, and then that way everybody had feedback and felt listened to, and that was really a key part of it. So there's 32 hospitals in Chicago, and we ended up getting 20, all the major academic centers, to be able to submit their data to this public health hub, and we're continuing now to try to reach some of the lower tech hospitals where they don't have a dedicated huge IT department to build this and offer that service. And then there's dashboards, and there's this aim for real-time data, ADT data, as part of our second phase of this, because that then automates some of the bed capacity information. It was too big a lift in the initial phase, but now we're kind of going back to that. Public health sees this as sort of a key piece of infrastructure that could help them moving forward. It could help them with things like Lollapalooza, which take place in Chicago, or the Chicago Marathon, or other big events. And it builds this culture of data sharing where the public health is in the center. And so the next two slides are kind of some examples of the type of data that we were able to generate, but there's lots more, and this is sort of foundational for what the health department does. But this just shows race, ethnicity, and age, so it's sort of these three variables and counts over time, and you can see this sort of really nice bimodal distribution. This was last year that we produced this, and also just differences by time. And you could see there's like a early spike in the Hispanic population in Chicago that declined, and then there's this, it's really interesting from an epidemiologic perspective. And then the other thing that we did was we compared different data sources that were getting submitted, and as a health system, we sort of had mandates to submit data from two different sources for bed capacity. One was a system called EM Resource, and the other was a system called HHS Protect. And there were these really nice articles last summer about kind of the conflicts between bed capacity systems. Anyway, we were submitting data, and we were able to validate that the data getting submitted to these two different systems, both manually reported, both often by different groups, really were very highly correlated. And that was really reassuring for us. Now, our view is that this infrastructure could be a really novel way for public health to do its work, to automate the surveillance aspects of it, but also be something maybe even more if we can design it the right way. And so in the center is this clinical registry, and right now we have these input data, HL7, CCDA, REDCap forms. Our vision is, what if you could actually have FHIR submission of data, where instead of a push, it's a pull. And you have bulk FHIR as the mechanism that data comes from the EMRs to the health department. And what if on the output side, you could provide data in these two different ways? One is for reporting all the way upstream to the federal agencies. You use FHIR as the payload for data submission, rather than all the different ways we submit data, including manual. And that could even include ECR, electronic case report forms, which is this way of doing FHIR-enabled forms. And what if you could actually make these data available to providers using the bulk fire approach of data at the point of care? So this is sort of like the really ambitious, could we do this type of idea, but no reason why we couldn't. Public health has actually adopted the Data Hub now as sort of a foundational piece of public health infrastructure. And in the current state, we've grown from just bed capacity and ELR to include scheduling. Chicago had a really nice pilot of ZocDoc being kind of in the middle for scheduling for vaccination, and those scheduled appointments, that information comes in. We also get data from our immunization registry, iCare, at the state level, that's coming in, and we have also future directions, including the HIV STI program. We've spoken with that group at the health department, and also one really neat project called Ripple, which is the Regional Innovative Public Health Labs. It's actually the sequencing of virus so that we could have the actual strain variant types loaded. As these are all linked, you end up getting a really powerful epidemiologic tool for the health department that brings all the data together. The other thing we sort of found is that COVID was really fast moving. There tons of agility was needed, and the way I was thinking about it is every quarter we almost had a different concern, a different issue, and cloud was a big enabler, as I think people have probably been saying in this conference, for this agility. We were able to shift what we needed to do. So the first was bed capacity data. That was an initial aim, and we ended up being able to compare these different systems for reporting, and we're able to link the data and turn that around. Longitudinal data, this became a big deal as we went out, because long COVID is sort of something that's become it is a really big concern. Being able to have that longitudinal data and start to think about the architecture of a data ecosystem to look at long COVID and its total burden in the population. Vaccine scheduling then became the issue once the vaccine was available, and being able to monitor the availability of vaccine. And initially there was this huge shortage of vaccine versus demand, and that had sort of faded. Then new strains, new variants, and molecular epidemiology, we were able to build that in as a part of the infrastructure. And as we look to the future, real-time, real-world evidence, I think, is where we're looking to go. Now, we're fortunate to be able to partner with Amazon in terms of looking at how we take and build a reference implementation of this infrastructure. So we did this all very quickly. It was sort of like an emergency from the spring all the way to the fall, but then in the fall we could say, you know what, how do you build this the right way and make this available as a key set of tools? And so fully in AWS, we have, and it's laid out in this slide, all the different sort of microservices that we use to go from ingestion of these various kinds of data all the way out to reporting. And the thing that HealthLake does really nicely is, not only do you have the Fire API in terms of if you wanted to build apps that point, in terms of Fire-enabled tools and use that API layer, but you get to use all the AWS kind of microservices like QuickSight and as kind of your analytics layer, and SageMaker for the machine learning piece, which we've been sort of looking at how do we leverage. We've open sourced this code, and it's there in the slide, and so you can see that link. And our thought is that this should be kind of a reference implementation for how you build a public health data lake, as we've done. And then there's been a blog post kind of describing this work that we were able to put out there, and I'd encourage you to go look at that as well. So as we look at this, what we have found is that public health infrastructure, there's a lot of room to modernize. There is a lot of interest at the health department level about how do you bring all these tools together and be able to do kind of epidemiologic work that you'd normally do with fragmented data sets, but unify the data. But we found there's even other sort of tools that the health department just really liked, and the biggest was actually data analytics tools in the cloud. As we started going through this, SAS, which is kind of the workhorse statistical tool that the health department uses, that was really on everyone's workstations. being able to have SaaS in the cloud was kind of a key enabler for them, because you have compute that scales and can go up and down, and you have a lot of power, and being able to have the reliability of that, plus it's closer to the data, that was something there was a lot of interest. The second was cloud data workflows and data science toolkits, in that order, I would say, in the priority order. Public health is really interested in the idea of a data repository in the cloud, because there's a lot of options generated by scalable data storage. You can, it's not the constraints of a capital budget or the timelines to scale the size of the data that you can store, and this has been kind of a really great journey with them. And the final thing that we've sort of been looking at, and we have, is an MPI, a master patient index, to link the ELR and CCDA data. The public health has tools, and they have a process where they already do linking. We've ported that into code, and that now runs against the cloud. We've been looking at privacy protecting record linkage, and there's some open source tools out there that can create a non-derived hash, and that hash is the way that you can then share de-identified data but still link the data longitudinally. Okay, and just so the last couple slides, so one additional Amazon HealthLake use case that we're working on is a population health registry, a demonstration project. And we've been funded by the Robert Wood Johnson Foundation to sort of take some of the work and the thinking that we've done around this COVID-19 data registry, but apply it now from a health equity lens. A gap we've noted in our own population is that there's this idea called clinical inertia. So let me tell you a little bit about Rush and then clinical inertia. So Rush, we're a 664-bed hospital. We're located on the west side of Chicago. The neighborhoods around our hospital have among the lowest life expectancy in all of Chicago. We actually have this really nice map that shows the life expectancy by L station. And if you go about 10 miles to the east of us, you're in the middle of the city, you're in Streeterville, and the average life expectancy is like 85. When you look at the L stop right near our hospital, it's 13 years lower. So it's 72. And it actually goes even lower if you go further west. So it's like almost like this, this real story around the zip code that you live in being more important than the diagnosis code, which is sort of one of the sort of ways we've described it. But it really speaks to a lot of endemic issues like poverty and also equity in all sorts of ways. When you look at the prevalence of all sorts of diseases, they're higher and with higher complication rates in these same neighborhoods. And that goes from HIV, sexually transmitted infections, cancer outcomes, and COVID outcomes generally. So it's across the board. One thing we have found is that access to care and clinical inertia are key drivers of that health equity difference. And so access to care is, do you have a primary care provider? It's that simple question. Clinical inertia is, when you have a problem, does it get addressed? So we're looking actually at hypertension. Hypertension clinical inertia is the time from an elevated blood pressure to the time that the drug gets adjusted, or the time that a drug gets started. So are you actually managing hypertension aggressively? And so we're basically taking, for our population, our entire population, the data from our EMR, moving it to HealthLake, and then we are mapping it all to the HealthLake data model, so FHIR, and we're studying the gaps in hypertension care for that West Side community. And we're bringing in basically 3 different data sets. We've got our Epic Caboodle data model. We've also got Blue Button. We have the Blue Button license, and so we're able to pull down Medicare claims for this population, and so we're really focusing in on the Medicare population. And then we have a partnership with a company called Higgy, which has ambulatory blood pressure measurement stations, and there's a picture of one on the slide right here. And that Higgy station gets us basically the blood pressure measures in an ambulatory setting, so you can look both in and out of the hospital or the healthcare setting. And with this complete picture, we're able to look at the full spectrum of the longitudinal care for hypertension. And then our idea is the analytics part of this will be an app that basically looks at health equity. And again, this is a reference implementation of how you do health equity, population health on a platform. And this will then move from hypertension to other chronic diseases is the way we think about it. So it's a clinical registry in the middle, but then this app layer and an overall picture that you can move across use cases. And this is completely on HealthLake, and so we're kind of moving through this process. So just to wrap up, this has been like an amazing journey for us. I think we're really excited about where this can take us and our use of cloud. Definitely the agility of cloud-based services has compelling value for novel use cases in public health. I think this experience has shown us that and has shown the health department that. And these themes of data integration, patient matching, and ease of reporting, they've been recurring over the COVID-19 era, but they have applicability to other use cases. In our view, the ideal scenario is to combine standards and reporting needs. Take the data that's out there to solve some of the fragmentation, but with the idea of linking smartly so that we can generate real-world evidence. And public health really is a unique, trusted partner in this data ecosystem and serves a vital role. I mean, you could imagine what if this hypertension clinical inertia was something that the public health department had a key role? Prior to COVID, chronic diseases were the #1 public health issue. Diabetes care, you can imagine public health having a key role. So there's some ways this could go that we would love to see. And then finally, Amazon HealthLake, it's well suited for use cases involving clinical registries with this analytics layer and advanced analytics in particular. So thank you, I think on behalf of both of us. And please complete this online session survey if you can. And I think we're open for questions.
Thank you, Dr. Hota, for leading in this really critical public health infrastructure space. It's long overdue. How do you see this scaling up to the national level so that other public health departments do a similar thing? And then what are your thoughts for this becoming a research tool for public health academia and teaching the future public health workforce?
Yeah, thanks. That's a great question. So I think, so first, how does this scale or how does this become a national model? So I think there's some things we learned and that could inform that. In terms of what nationally is happening, Jen Layden was actually a key person, the key person for this whole effort. She was the chief medical officer for the Chicago Department of Health, and she's now at CDC. So I wanted to call out her, and acknowledge her. At CDC, I think one of the things that she's sort of coordinating or working on is how does this work become, or this type of work become a national model? How do you have data sharing with the privacy protecting in a way that keeps local control of data but also enables a national model? And she's looking at that. I know ONC and CDC both have been thinking about how do you have regional data sharing in a way like this, but maybe linking in with partnerships. And there were some RFPs that went out earlier last year linking up with health information exchanges. And we've spoken and advised some of those HIEs in terms of how do you share data from the HIE to public health. Chicago is unique because we didn't have an HIE kind of going into this, or maybe we're not unique, but there are some regions where the HIE already exists, and that would be an amazing tool to leverage. So you don't have to build in all these direct to hospital connections, but you can go directly to where there's a lot of data. Now in terms of data sharing, the data governance was a key issue here, and we actually to date have not shared these data with the partners in an individual level. Public health was really clear for all of this that this was being used for the public health response and not for, there's no IRB approval for this, and so they didn't feel ready to share the data in anything other than aggregates. It's something CDPH has thought about and wants to do in the future from what they've told me, but not there yet. I think in the age that we're in, I think the privacy is paramount, because as an individual, there could be a backlash, it feels like, from a optics and otherwise perspective if the data is shared inappropriately at a patient level. And I think the health department is really aware of that. But there are ways that the data could be shared for research perspectives. One thing we're a part of is this other project to look at long COVID. It's called the Inspire Registry, which is CDC funded, and we actually there have a personal health record app that individual participants in the study, they agree up front to allow their data to be shared for the study, and they can control what data gets shared. That, and we're exploring if that's a viable model for something like that. So I don't know if that answers your question, but some thoughts.
Hey, Dr. Hota, you mentioned the problem of pen, paper, fax, and then you talked about FHIR. With FHIR regulations that might be in place and widespread adoption of that, do you think that problem of pen, paper, fax and the loss of data will eventually go away? Yeah,
you know, the reason why it's pen, so I actually worked on public health informatics. I've been working on public health informatics projects since probably 2005, when we had a project called BioSense. I don't know if you guys remember, if anybody remembers that. It was after the anthrax attacks, and there was like tremendous federal funding for that. And at that time, the thought was, we're gonna solve this. Like the thinking was, this is gonna get solved, there will be data interchange and a national infrastructure, and never happened. Public health tends to not get the funding that's needed to really enable digital transformation at scale. And the amount that we do have is because of the meaningful use, mandates, like ELR transmission, but it could always get better. So I wonder what the model is. It feels like this is the time if we're going to do it, but we said that then. So I don't want to be too jaded. I think that FHIR offers an interesting model because it can really reduce the cost of getting individual atomic data elements from specific individuals to a central place, and do it in a way where it could even be on demand. I think some of the stuff going on with smart health cards is really interesting, like with the immunization data to go. And what would really be amazing is if at the individual level you could give permission for data to get shared and even have revocation of data on demand. Because then public health emergency happens, you go out, get people to share their data, it's de-identified even, and then it comes back when they don't want it to be used. That may work. Mandates might work, but we've seen the pushback with mandates. I think we're limited in the scope of what mandates could do. And or some federal infrastructure. But the one problem with federal infrastructure is the culture in public health is local health departments really need to retain central control because they're sort of the agent of action. So it feels like having the data flow to a local health department, then up the chain with the right level of governance is the sort of pathway of that respects the culture of public health. So maybe a long answer, but that's kind of my thinking about it.
Any other questions for our speakers? All right, if no other questions, thank you very much for your presentation.
Thanks, everyone.